Good. Welcome to the Siren Hot Topics discussion this morning. To screen or not to screen? That is the important question. I'm really delighted to be doing this with friends and colleagues, uh, and I'm excited for the conversation. So, before we jump into actual content, I really want to express appreciation to the Robert Johnson Foundation, who's been a longtime supporter of Siren, and without whom this webinar would not be possible. I also wanted to share a few words about SIREN for those of you who aren't yet familiar with us. So the Social Interventions Research and Evaluation Network is a research and dissemination center at the University of California, San Francisco. Our mission is to conduct, strengthen, and synthesize research on social and medical care integration, and then put it into the hands of people who can use it, hopefully like many of you. One of our most beloved and well-used resources is our evidence and resource library on our website. You can find research and implementation tools about healthcare-based social care. It's free, it's really easy to use. It's maintained by the magnificent Alejandra Rocha Gonzalez, and we would love for you to be using it. So please go check it out. And if you have any questions about it, let us know. And then if you are interested in staying up to date about research in the field, do sign up for our monthly newsletters. If you haven't already, you'll find a synopsis of recent relevant research published that month on social care integration, and you can learn about relevant news and events. So again, before we dive into content, just a couple of webinar logistics. The webinar is being recorded. We'll send a link to all registered participants when it is available. We also welcome your questions, so please use the Q&A function, not the chat function, to ask your comments and add questions. I think that's it on logistics. So now for the fun part, why are we talking about screening? So either you are all here as Shakespeare fans and found the title of this webinar simply irresistible, or perhaps you, like those of us at SIREN, are just feeling a real tension about the future of social risk screening in US healthcare settings. Assuming the latter, I'm just going to call it out. So, on the one hand, over the last 5 to 7-ish years, we've seen multiple policy pushes encouraging screening for social risk factors, social needs, health-related social needs, whatever you want to call them. Some of those policies came from CMS, like the Inpatient Quality Reporting Program and the Outpatient Merit-Based Incentive Program. And even as some of those have been rolled back under the Trump administration, there are nonetheless other federal encouragements for social risk screening, both from the administration and then from other standard setting organizations like the NCQA, the Joint Commission, and even others from individual state Medicaid or insurer initiatives that incentivize social risk screening for kids and adults, inpatient, outpatient settings. It's all over the place, not all over, but all over the place. On the other hand, researchers, practitioners, healthcare system leaders have appropriately asked whether social risk screening is feasible, equitable, beneficial. They're asking whether screening could lead to harm, whether it could worsen inequities by exacerbating distrust, whether there's just too high an opportunity cost for an overburdened healthcare system, and maybe too small a benefit to patients because of a broken social services safety net. And then, of course, whether there's a risk of worsening the broken social services safety net by medicalizing social care, which is a topic we've discussed in prior SIREN webinars. And you can view those online if you go to our website. So taking all of that in, there are a lot of different directions we might head. We might see such scarcity that healthcare systems abandon both social screening and social services referrals. We might just ditch screening and instead provide universal resources or referrals to social services. We might try to improve the quality of social risk screening to improve the experience for patients. And we'll have a webinar on that in, I think, early February. So stay tuned. We might also improve, say, just the quality of the data being collected by improving social risk screening and training for social risk screening. We might just say that whatever the downsides of the current system, the upsides of screening are still net positive. And I confess, of all those different options, I don't know where the US healthcare system is going to land. So given this big decisional dilemma, to use PCORI language, which I assume many of you are familiar with, you can imagine how important it is for there to be researchers asking questions about social risk screening and screening alternatives. So the research we're going to hear about today comes from two teams that have been at the forefront of social care research. Both have taught me so much about what it means to do rigorous patient and community informed research. It just so happens that both of the studies being presented were conducted in pediatric settings, one in inpatient, one with outpatients in primary care and emergency room settings. But I don't think the lessons from the studies are limited to pediatrics populations. So we'll hear about these two relatively new studies, and then I hope still have plenty of time for a lively conversation about the future of screening. So without further ado, I am honored to introduce our two presenters and discussant. So first, Dr. Jen Makelarski is an epidemiologist whose work centers on assessing and addressing basic needs with a focus on reducing food insecurity through innovative interventions like Feed First, a hospital-based food pantry program. She specializes in developing and evaluating resource referral programs like Community RX. Dr. Danielle Cullen is an assistant professor of pediatrics and pediatric emergency medicine at the Children's Hospital of Philadelphia, where she also directs health services research for the Division of Emergency Medicine. Her research focuses on advancing health equity for socially disadvantaged children by addressing unmet social needs and improving family engagement with resources. And then finally, I've also asked Dr. Sarah DeSilvey, over her objections, to join us today to share some of her observations about the state of screening policy in the country. Sarah is a rural family nurse practitioner and faculty member at the University of Vermont Larner College of Medicine, but you might know her best as the terminology director and general ringleader and cheerleader of the Gravity Project, where she leads efforts to develop data standards for social care integration and to advance health information interoperability. So we'll get to hear from Sarah after the two presentations. And I think with that, I get to stop sharing and I'm going to turn it over to Jen. Welcome, everybody. Thank you so much for being here.
Thank you so much, Laura. I'm so grateful to be here and I'm really excited about the discussion. So I'm going to jump right in. Let me test my sharing out here. Good. Everyone can see my slides. Awesome. Thank you so much. Now, can I advance them? Yes. Okay. The work I'll present today was funded by the National Institutes of Health. Dr. Stacy Lindau was the PI on this grant, and her disclosure is here. I have no other disclosures to report. Community RX is an evidence-based resource for social care intervention that our team has developed over the last 15 years in partnership with Chicago's Southside community. More than 115,000 people have received some form of Community RX. Community RX has been iterated to meet the needs of different populations. You'll see some of those listed here. Today, I'm going to talk about Community RX Hunger, which was designed for families of hospitalized children. It's called Hunger because we were especially interested in providing resource referrals that addressed food insecurity, which is a prevalent social risk among families in our hospital setting. The Community RX Hunger intervention has three essential components, and the delivery of those components begin during or shortly after the child is discharged from their hospital stay. The first component is education, and that's brief scripting that describes resources that the families might need and includes reference to resources that address social needs, like food pantries. The next component is activation, and that's when a navigator walks a person through a Healthy RX. The Healthy RX is a list of resources that are located close to the family's home. At that point, the navigator also tells the person that they're available to help find other resources and that they're going to reach out by text. The last essential component is what we call boosting, and that's delivered once they've been discharged, and it's over time with messages that are pretty frequent early on and then phase out over 3 months. Those messages point people to other resources, and they also ask, do you need anything else? People can respond to those automated messages to connect directly with the navigator and then ask for specific resource information. So there's a couple of things I want to point out or reiterate for the purposes of our conversation today. That initial Healthy RX, this is just a couple pages from one example, has 24 resource types and is delivered universally. So it's given to everyone that was enrolled for the intervention. So the intervention itself, and more specifically, those resources on the Healthy RX, they're not determined based on a social risk screening like the Accountable Health Community Screening Tool, or based on some other assessment like asking people what resources do you want or what do you need. During boosting, so remember that's the text messages from the navigator, people can self-identify resources that they need. There's no formal assessment still, but they're asked questions like, are there any other resources that I can help you find? We conducted a double-blind randomized control trial to test the impact of CommunityRx Hunger. We enrolled 640 caregivers of hospitalized children from our children's hospital at University of Chicago, November 2020 to August 2023. Folks were stratified by their baseline food security status using the 18-item USDA tool, and then randomized to get either usual care or usual care plus CommunityRx Hunger. We followed up at 1 week, 1, 3, 6, and 12 months. Our primary outcomes were self-efficacy for finding resources at 12 months among those with food insecurity at baseline, and then satisfaction with care among all participants. We assessed a number of other outcomes, including health-related social risks, resource needs, child's health, and child's acute healthcare utilization. As a reminder, that risk screening and needs assessment wasn't part of the intervention. It was a totally different person doing it as part of a research survey. Also note that many of our pre-planned analyses included only those with food insecurity at baseline. At the time when we wrote the proposal, we thought those were the folks that were going to see the biggest impact. So some of my findings are focused on only that group. And I'm just reporting on a couple of these outcomes today. Nearly all participants were female and the parent of the child. 79% were Black or African American and 14% were Hispanic, which reflects the population surrounding the children's hospital. More than 3/4 of our families had an annual income less than $50,000. That also reflects our population. And just over a third were food insecure, again, based on the USDA's 18-item measure of food insecurity. We asked people if they needed the 9 resource types that you see listed here as part of the survey. You can see resource needs were common at baseline. So nearly 3/4 of all participants identified at least one need for their family. The most prevalent was some resource to support financial assistance. Before I move on to some of the outcomes, I just want to highlight the engagement with the intervention. We really weren't totally sure what to expect when we were delivering those automated text messages and giving people the opportunity to ask for more resources. We had done some other trials where we had people respond asking for resources where engagement was really fairly low. Everyone got that initial delivery of the Healthy RX. After that, during boosting, we were surprised to find that 73% of intervention participants responded to a navigator's text at least once. Very few, 3%, opted out of all text messages. When responding, some folks were just saying things like, no thanks, I don't need any resources right now. But about a third asked for some other additional resource information at least once over the intervention period. So that means they got another Healthy RX from the navigator. They would text saying, I could really use a place to buy hearing aids. The navigator would call them, they'd help figure out what address to use, and they'd send them that new list of resources. We assessed experiences of discrimination and satisfaction with discharge 1 week after discharge and conducted a non-inferiority analysis that included all of our participants. If you're not familiar with a non-inferiority analysis, it means that we're testing to make sure there is not a meaningful difference between groups. So we wanted to show that giving the intervention universally wasn't hurting people's experience during the child's discharge. So Laura referenced this in her introduction. To do this, we set an empirically informed, acceptable non-inferiority margin. So that's basically what difference is small enough that it really doesn't matter. It's not a meaningful difference. The top figure here shows that the 95% confidence interval for the difference in groups for experiences of discrimination does not cross our non-inferiority margin. That's the blue line. So this is evidence that the intervention didn't promote experiences of discrimination during discharge. People didn't feel like somebody was calling them out, because they were getting this thing during the discharge process. Just to be, or the second panel. So actually, I'm sorry, the second panel. Panel B shows the results for satisfaction with care. In this case, our 95% confidence interval did cross our non-inferiority margin. I just want to be clear that that's not the same thing as saying there is a significant difference between groups. It just means that the difference we found was bigger than what we said was acceptable. We were using a measure that had a 100-point scale, and we had determined based on the standard deviation that an acceptable difference would be less than 1.6 points, and it was about 2. So we would need to do more work to really understand if how the intervention affected satisfaction with discharge in a meaningful way. I also want to point out that we found that these findings were not moderated in any way by baseline food insecurity status. The results were the same either way. We also do have some qualitative findings that suggest discharge wasn't the best time, which could in part explain our finding regarding satisfaction with discharge. Folks were saying we were just getting too much information. It wasn't helpful to do it at discharge. Among children of families who were food insecure at baseline, that's 223 of the 340 families, the 640 families, we saw significantly lower rates of ED use in the 12 months post-discharge, and then clear trends of lower rates of hospitalization in the 12 months post-discharge. These figures show incident rate ratios. So if the confidence interval is to the left of the dotted line, which is 1, then that means we're favoring the intervention, that there are fewer visits for people in the intervention group. Shown in the maroon box, I think you can see my pointer right. There we go. Is a sub-analysis of that group of people that asked for additional resources. So that especially engaged group, we saw that they were actually driving a lot of these findings. Again, these are incident rate ratios, which I know can be difficult to interpret at a glance. So I also included the proportions. You can see that 30% of children in the intervention group versus 52% in the usual care group had at least one ED visit in the 12 months following discharge. So it's a pretty big difference. I've highlighted several times now that there was this more engaged group that were asking for resources. So I want to show you what kinds of resources those folks were asking for. We found that many overlapped with what was on that initial Healthy Air Racks. But sometimes people were asking for a resource at a different location. So we were giving them resources that were close to home, but they might call and say, I'd like something close to work. I have to leave work to go to the food pantry. Can you give me a different location? Or they were just looking for a different option. We had given them 2 places that provided a specific resource. They could ask for something else, right? Importantly, about a third of requests for additional resources are what we classified as high acuity needs. These were things like mental health, so counseling, a safety hotline, or immigration support. I also want to point out that this is stratified by food security status at baseline. And so we were seeing about as many requests come in from the food secure people as the food insecure people. So if we had used that one risk factor to target the intervention, we would have missed a ton of opportunity to give people resource information that they were going to ask for. Finally, because we're talking about screening today, I wanted to show you what we saw when we compared the participants' resource needs assessment results to the Accountable Health Community's risk-based screening tool. We treated the needs assessment, so when we're saying, is this a resource that your family needs, as a gold standard or a diagnostic test, if you will. And then we treated the AHC screener as the screener. The AHC screener's sensitivity for detecting needs ranged from 29% for safety to 63% for food. So, in other words, I'm going to use transportation as an example. Because the sensitivity is 43%, it means that 57% of people who said, I need a resource to help me with transportation, actually screened negative for transportation difficulties based on the AHC screener. Just for these four kinds of resources, not all four or all nine resource needs that we asked about, 39% of participants had at least one need that wasn't captured by the AHC. I think it's also important to note that sensitivity varied by some sociodemographic characteristics. So, for example, people that had incomes greater than or equal to 50,000 annually were far more likely to have a food need or a housing need that they identified themselves that was missed by the AHC screener, compared to people who had incomes less than 50,000. So I probably have, I think saying 100 questions about community X hunger and its impact is a low estimate, but I'm going to leave you with just a couple before I pass it off to Danielle. We've really been thinking a lot about, one, what are the mechanisms, like what explains these effects on acute healthcare? So that's one piece that maybe doesn't have a lot to do with screening. We're also thinking about what happens if this isn't universal. What if it was driven by social risk screening or some kind of needs assessment? And if we need to do that to conserve resources, what tools should we use? Do we need to worry about worsening disparities? What's the best approach? And just trying to figure that out. Very quickly, I want to thank the co-investigators on this project who are listed at the top, and the wonderful people of the Lindau Lab who are the boots on the ground doing the work of collecting data. They man our hospital-based food pantry, which has 11 sites and is this massive undertaking. Design complicated databases, do all kinds of analyses, and generally just amazing things. I'm really grateful for our team, so I have to give a good shout out to them. Thank you so much. My email is here if anyone wants to reach out, and I'm going to pass it off to Danielle.
Danielle, as you set up your slides, Jen, I'm going to correct you because the people at the Lindau Lab are not manning, they are womaning. If you look at that slide,
Good.
they are the boots on the ground, and it's an incredible, it's an incredible team. But also, there are a few just technical questions that I think you might be able to handle in the chat. Some of them we can get to orally after the presentations, but if you want to just take care of some of the questions that are easy to take care of via text, that'd be great.
Yes, will do.
Danielle, we are turning it over to you.
Well, thank you so much. I am honored to be here today to talk about our recent study, Socially Equitable Care by Understanding Resource Engagement, or the SECURE trial, so much of which has been built on the work done by all of the amazing people who are part of this panel and the many friends and colleagues and mentors that I've seen in the chat. It's so nice to see everybody here today. We have no disclosures, but the study that I'll be talking about was funded by the William T. Grant Foundation and the Emergency Medicine Foundation. So, like Jen was saying, in the context of all of these questions that Laura set up for us, we really entered the study thinking about, does screening for social risk impact resource desire? Will it lead to higher rates of elicitation of resource desire or lower, and more or less connectivity? And how is it that we can best facilitate family level engagement with social resources from the pediatric healthcare setting with all of the interventions and implementation pressure that we're facing? So we developed and conducted the SECURE study, which is a single center, multi-site randomized control trial with a mixed method design with the primary intention of evaluating the impact of social risk screening compared to alternatives on desire for and engagement with resources. All the while, we were trialing utility of an electronic geographically searchable resource map in partnership with Find Help, tele-resource navigation by an opt-out process that happened after the point of medical care, and conducting the study with multilingual methods using 6 different languages that were most common to our patient population across sites. Throughout all, our goal was to be as pragmatic as possible, centering family autonomy and perspectives, offering resources to everybody regardless of how they responded, and co-developing our procedures with both families as well as clinical staff, collecting data to inform implementation. We conducted the study at 3 sites within the Children's Hospital of Philadelphia, the hospital's main emergency department, as well as 2 primary care sites, 1 urban and 1 suburban, selected for demographic diversity. We included caregivers of patients aged 0 to 25 years who had a smartphone and spoke one of our 6 study languages. We excluded any caregivers of patients who were anticipated to have social work involved in their care as a routine part of their care, either with presentations for complex care management or with chief complaints like behavioral health concerns or suspected child abuse or neglect. After we verified eligibility and recruited caregivers, they were then randomized in a 1-to-1-to-1 ratio across these 3 different randomization arms that we'll talk about in a second. All of these remaining study procedures then occurred on the caregiver's own smart mobile device in the language of their preference, using multilingual technology through REDCap, which then followed caregivers through all study procedures. Our first randomization arm was a social risk screening tool. We used an adapted version of the WeCare screening tool, which assessed for social risk or material hardship in 5 different domains: food, housing, transportation, utilities, and childcare. We used this screening tool because in addition to the risk-based questions, there's also a follow-up question that asks, do you want help with this? So more of a need-based assessment. Additionally, in the domains of food, housing, and utilities, there's stratification to identify emergent risk, for which we sent an automatic alert to our project-specific social worker for same-day contact. Our second randomization arm is what we call a resource menu, or potentially a universal offering, a needs-based assessment tool, where we ask families if they would like information about any of these types of programs, and they could check as many as are applicable with no prerequisite disclosure of social risk. Our third randomization arm was a self-navigation arm where there was no assessment tool whatsoever. All caregivers were then automatically redirected on their smart device to a randomization arm specific duplication of a Find Help geographically searchable electronic resource map in their preferred language. All caregivers also had the option for a same-day social work consultation for any self-identified emergent social or safety risks. Within 24 hours of enrollment, all caregivers received a text message notifying them that they would be called within the next few days for individual resource navigation unless they opted out. By 5 days, all participants received that phone call. At 30 days' time, consenting caregivers received a survey in order to better understand how it is that people felt that they engaged with the resource map, their preferences through this process, and experiences overall. And then we purposefully sampled caregivers across randomization arms for semi-structured qualitative interviews. Overall, we recruited and randomized 3,949 caregivers across our 3 arms. You can see the overall demographic distribution here. Notably, about 9% of our study participants preferred non-English language, which did achieve proportional representation by our study sites. Also of note, about 67% of our caregivers reported that they had previously used some sort of social resource. So how is resource desire affected by screening? As you can see in this table, across almost all of the 5 main social resource domains, we were able to identify a higher proportion of caregivers who desired resource assistance with use of a resource menu as opposed to the screening tool. I'd particularly like to highlight this bottom row, which demonstrates that with the resource menu, we were able to identify nearly 10% more families who wanted assistance, desired resources in any of the 5 resource domains as compared to the screening tool. When we stratified these results by preferred language, they were even more impressive, with caregivers who preferred a non-English language having a 2.7 times greater odds of reporting desire for resources when presented with a resource menu or needs-based assessment rather than the screening tool. The next question that we have, and that's often asked to us, is, okay, but without screening, would we miss those with emergent risk? If you remember that we care-based screening tool asked additional questions to identify emergent risk in the domains of food, housing, and utilities, which in that randomization arm identified about 3.5% of caregivers. We then asked all caregivers across arms if they had any urgent safety or social concerns that they wanted a same-day social work consultation. And you can see the results here. Once we adjusted to include those who are already identified and referred based on emergent risk, we found no significant difference between randomization arms. So stated differently, caregivers self-selected into the urgency of social work consultation that they felt that they had. And additionally, there were caregivers in the screening arm who felt that they had an emergent risk that actually wasn't identified through screening processes alone. So how did screening affect the use of the resource map? As a reminder, we automatically redirected all caregivers regardless of their responses to our assessment tools. And we found high overall utilization of our resource map, with about 40% of participants stating that they made a search on the resource map either for themselves or somebody else. Interestingly, about a third of our participants, similar to what was found in the community RX work, shared this resource map, these resources, with other people outside of the study. There were no significant differences between randomization arms. So what influences engagement with individual navigation? Frequently, when discussing social risk screening, it's said that if we identify those with the highest amounts of social risk, we can determine who it is that need more individual navigation. What we found in our results is that across randomization arms, there was a dose-response relationship between engagement with resource navigation and the number of domains in which caregivers said that they wanted resources. The lowest rates of engagement in resource navigation were among those who reported no desire for resources in the resource menu group, those who screened negative, or those who screened positive but reported no desire for resources. So otherwise stated, again, caregivers were able to self-identify the levels of support that they wanted, and that was the biggest predictor of whether or not they engaged with that more individualized navigation. In our qualitative results, again, we purposefully sampled participants from across all randomization arms to be demographically similar to those in our overall sample. But we oversampled Spanish-speaking participants, conducting 11 of our interviews in Spanish and 49 in English. Some of our results reflected those that are already previously described in the literature, but 4 novel themes emerged with concerns that caregivers had with documentation of social risk in the electronic medical record. The first with regards to visibility and stigma, especially with sharing of medical record information in the setting of 21st Century Cures Act. So caregivers said that when things are documented in their medical record, they're concerned, as has been previously documented in the literature, about involvement of child protective services. But there was also concern about how it is that doctors would view them as patients. One participant stated that it's kind of uncomfortable, especially if you want your doctor to think of you one way and your answers might make them think of you in a different way. Caregivers also reported concerns with permanency, expressing that while their social conditions may change over time, once they've typed something in the baby's chart, that it becomes a forever thing. Another theme that emerged was concerns over what we would call in the medical field anchoring bias, or undue tethering of these social concerns to medical complaints. As one caregiver expressed, because I could be there for something like constipation, and then you see something like I couldn't afford food and think that I'm feeding my son bricks, and then they got constipation. Finally, caregivers reported concerns about sharing this data with insurers, feeling that, as one caregiver stated, it's another way for insurance companies to not cover and not help patients. I don't know, that's being shady to me. When we ask caregivers about strategies to increase their comfort with any type of social care protocol, caregivers stated items revolving around these 4 additional themes. One, situational awareness, saying that if there's a serious medical diagnosis, nobody wants to talk about community resources unless they're about to be affected. You know, if someone literally received a life-changing diagnosis, you want to calibrate or recalibrate whether or not that meeting even needs to take place. With respect to the results that Jen presented, similarly to that, to not necessarily wanting to be engaged in resource navigation at the timing of discharge, caregivers felt a lot of stress, especially in the emergency department with acute medical diagnoses, and preferred for any type of social care to then happen in follow-up asynchronously with the medical visit. Another theme was in training. One participant said, I think it could be somebody that's had some sort of training and talking to people and understanding. It shouldn't be something that's just thrown around and asked to be something that's asked. The thing is, you wouldn't want people to feel like, oh, they don't actually care. Communication and consent was additionally very important. More communication being better, and also for caregivers to be asked whether or not they would be okay with documentation of any health-related social needs that are identified. The final piece that I want to highlight is that of autonomy, with caregivers expressing a desire to have the option to answer or not. One caregiver stated that it's not like we're forced, you know? I don't think it should be a requirement. I think that's getting too personal. Overall, our study found that a resource menu without preceding screening performed best in helping identify caregivers who desired resources and identify that social need. We also demonstrated the utility of electronic geographically searchable resources automatically loaded on smart devices. That engagement is predicted by desire for resource support, regardless of what screening results say, and that we were able to achieve proportional representation with multilingual approaches. Recommendations from the study are really for a tiered intervention. Whether or not any type of assessment is done, notwithstanding, we recommend that there are electronic resources that are provided for all, tailored referrals or resources provided for those with identified needs, and individualized navigations for those who desire it. Additionally, if any assessment tool is being used, we would recommend that it's electronic, caregiver-facing, and needs-based rather than risk-based. All of these actionable items shift the power back to caregivers to self-select what it is that's right for them, highlighting more equitable reach and programmatic features. And then finally, with documentation, we recommend prioritizing caregiver concerns and preferences, considering opportunities to clearly communicate procedures with families, allow caregivers the opportunity to opt out of assessment or documentation, potentially limiting visibility of documentation to only those who would be able to intervene or adjust care, and then considering timing for updates or removal to documented social risk or need. Giant thank you to the whole Secure team and all of our wonderful students who helped with recruitment of this study.
Amazing, Danielle. Thank you so much to both Jen and Danielle for those fantastic presentations and just such interesting work. Yeah, lots and lots of claps you can see going up there. Really interesting, such clear and helpful presentations. There are questions, and Jen, you've been doing a magnificent job of answering the ones that you could take care of that were just sort of detail oriented in the chat. Danielle, there might be one or two in there for you as well. But before we jump into actual questions, and I have a bunch, and I'm sure the audience is going to come up with some more. Sarah, I'm going to put you on the spot. Just because we have the privilege of having you join and having such a different perspective, a real policy perspective on what's happening in the field. And so I was hoping we could start with you just giving the audience a moment like around your expertise about what's happening. What does the landscape around social risk screening policy look like right now in the United States? Because every time you tell me something, I'm like, oh, I did not know that. Can you share that with the audience?
Yeah, I can briefly. I know we want to get to questions, but hello. Thanks for having me here. I'm in the presence of so many heroes of mine in research, so I just want to note that before I go on. So I'm going to give a couple caveats. Although the title, my friend Laura, is a dichotomy, so far I don't know if that dichotomy is actually borne out in our opinions. So I want to state before I go in that if I'm representing gravity, there's a couple of things to note. Number one, that pretty much all the findings that we saw presented are carried out in our own literature. You can see we're going to be sharing afterwards a brief called Best Practices in Validating Social Risk Diagnoses After Screening that we crafted with AHEMA. And we do have principles that we use that guide our work, like data principles about patient autonomy, centering, trust, and prevention of harm. So that being said, I think there's a lot of that I just saw that really echoes and supports the feelings our members have. So on the highest level, 2025 was a very interesting year, and I think it kind of landed in a place of like actually a step forward in some ways for social risk and health-related social needs screening. We saw early in 2025. So I'm going to talk about three different levels here. So we saw early the suggestion that inpatient quality screening, as was started in two different measures, social determinants of health screening and like SDOH 1 and 2, and social determinants of health positive in inpatient settings was likely going to be sunset. So that was an early signal. And so we didn't know what was going to be happening at the CMS level regarding health-related social needs or social risk screening when it came down, looking forward into 2026. Interestingly enough, based on the Medicare physician fee schedule that just came out, we can see that there's really a continuation of specifically Medicare's focus within its secondary prevention initiatives of trying to ensure that health-related social needs screening is persisting in existing models and included in new models like the ambulatory specialty model. And that's really from the classic, like, we want to make sure that we're addressing upstream drivers toward controlling chronic disease. So we want to make sure that individuals are screened for health-related social needs. And there's multiple programs within Medicare that speak to this, whether it be dually insured individuals, the annual wellness visit, or the incoming ambulatory specialty model. So CMS is essentially saying, especially with Medicare, that things are like status quo. What they did actually is kind of elevate to say not just social determinants of health or health-related social needs, but really trying to make sure that they focus on physical activity and nutrition as well. So there's an evolution of some of the supportive terminology and approaches within Medicare. But again, health-related social needs screening, as far as Medicare is concerned, is here to stay. And then one thing, when you step down from that, we can see that the NCQA HEDIS measures is still in existence, right? It's kind of like a emerging measure, and we see individuals trying to ensure how to improve their metrics with that. And that's a screen and intervene measure that aligns with gravity data standards. And then lastly, I would be remiss if I didn't say that activity on the state level is accelerating as well, right? So we see new states doing in lieu of services activities, focusing on screening for social needs and intervening. We see the existence and emergence of waivers in states to address screen and intervene for social needs. Like there's the New York waiver, which is evolving. There's the waiver in North Carolina that the Healthy Opportunities Initiative, which is changing, but still has a North Carolina focused all state initiative for identifying social needs. So that's all still happening. And then we also see the evolution of some waivers. Like I think about the Massachusetts approach, which because it's been so hardwired for so many years, it's actually evolving the level of severity of risk you have to demonstrate to qualify for some interventions. And these are not the universal interventions that we saw in the community RX or Dr. Cullen's model. These are things like produce prescriptions or medically tailored meals or specific disease-focused payer reimbursed initiatives. Like in Massachusetts, simple food insecurity presence is not going to be enough anymore. You actually have to demonstrate more severe levels of food insecurity to qualify for more advanced services. So all of these things are happening nationally. So basically, although some programs are sunset, it's still hardwired in most Medicare programs. It's a secondary prevention initiative trying to address upstream drivers. It still persists in federal payer measures like HEDIS, and it's still like existing and even accelerating in state-based initiatives like state waivers or in lieu of service. Whew! I think that's the answer for question one.
So
Okay.
much, just so much. And that's actually exactly what I was hoping you could share, because there's
Great.
just so much happening. It's really hard to track. And the fact that you track it is just phenomenal. And you're just an incredible resource. Before I let you off the hook, I'm going to
I
ask
know.
one more question, and it integrates, sorry, it integrates some of the questions that I think are open in the Q&A, but we can also maybe dive more into detail about them afterwards. So Sarah's asked this great question about like, did you find any benefits of screening aside from referrals? Like, was it a useful way of initiating conversations? And that question sort of ties into the question that I'm going to throw at you, and then hopefully Jen and Danielle can jump into that around Sarah's specific question. But I would just love for you, as not only as the terminology director of Gravity, but also as somebody who uses screening in your own clinic in Vermont. And you said that there's a lot of reasons that you screen, to sort of comment on what you think would be lost if, say, tomorrow, we just decided, oh, nope, no more screening. I don't think that's really going to happen, but I just want to hear your reflections on that question.
Okay. I am happy to answer that question. I want to note again, I am not a researcher like these amazing women who came before me. So I'm going to just note that first of all, what we say in Gravity very simply is that it's trust first, data second, right? So I have the honor. So in everything that we say, all of our papers, all of our literature, are that the trust part has to happen first, right? So there's two perspectives. And what I heard in these amazing, heroes of mine, their papers, is the limitations of screening toward identifying needs and possible harms rather than the dissolution of it. So that's what I was hearing, and I'm seeing some nods here. So there's two things I want to say. So I have the luck as a rural practitioner who's been practicing family medicine for a very long time. The trust part, I don't have to worry about that one. I have been taking care of the same family. So I have this bias. I am not a good member of the study because I have the bias of the perspective of a person where my patients and I trust me with all of their heart, right? And so that question of will Sarah take care of me if I say something, I don't have to worry about that one. So the primary limitations of screening, they know, my patients know, and they tell me this, that what if they identify a need, they know I'm going to follow up on it, and they know I'm going to take care of them, right? So I'm not actually a very good person to answer that question because my bias is exactly what Danielle was talking about in the addressing. How do we address it? We train people. We have compassionate care. We recognize risks. We like center people always, right? So I have that bias, right? And so that makes me a very poor person to answer that question. But I also want to note that in the settings where you have the practice, because we've been doing addressing social needs in Vermont again, also because Vermont's always into accelerate programs. We've been doing this for a very long time, and we have pretty good processes. So when risks are identified in screening, it's actually something that my patients and I can talk about. And so we look forward to understanding how it's affecting things like their diabetes or their heart failure or their depression or their anxiety. And so it gives me an opportunity to do exactly as screening's intended, to lean in and address unintended consequences or the risk of that identified condition. And the last thing I'm going to say is I'm in a very resource poor area in rural Vermont. And I work with very proud New Englanders, right? So number one, I often don't have any place to send them, right? So risk helps me stratify who I need to focus on, right? Because everything else I don't have food stamps I can give them. The food bank isn't open on every day, and they don't qualify for X programs, right? So there's that. I actually have to triage resources. And the last thing is I also have to convince people that it's okay to get help. Right. And this is something we saw probably in some of the answers that you saw with the coaching and in some of the research and in the addressing the strategies to address like concern. And the other one, like I have to like coach my patients to accept the community supported agriculture intervention. So without screening, I might give them the information of the CSA. It still takes me weeks to convince them to take it. Because they don't want help. They don't want to rely on the system. They feel like it must be help for someone else more than them. So, not a researcher, not one of, not the, like not a titan like these two, but that was like Laura, that was my answer to the question you asked. And now back to the whole collective.
Well, Jen and Danielle, do you want to weigh in on that question or related questions about, like I really appreciated, Danielle, in your presentation, you talked about um, ways to screen or the things that would increase comfort. But are you guys doing that training for providers? Are people still screening? Are you only using the resource menu? Like how are you now putting your findings into practice?
Sure. So, based on all of the mandates and incentives that you said, screening protocols are being rolled out in the risk-based fashion right now with additional need-based components in primary care and also in our inpatient setting. In the emergency department, we are just starting an implementation trial to put into practice what it is that we learned from the SECURE study. I think that to Sarah's point before, all of the decisions about how it is that you ask questions, if you're going to ask questions, how you triage resources, it's all so context specific and also specific to what it is that you're able to offer and the relationships that you have with patients. So I'll speak from my clinical home, which is the emergency department, which is it's very rare for us to be able to develop deep relationships with our patients. We don't have continuity of care. We don't have long times to establish relationships. And also most of our patients are presenting to us with in what is the most stressful moment of their life. Or of their moment, moment of their moment. And so thinking about opportunity to reduce any additional fear, stigma, competing priorities that they may have, and figure out a way in which we can address these things in parallel and not influence those thinking fast heuristics that we use in the emergency department are of critical importance to me and to our consideration of how it is that we implement this in the emergency department. I heard one piece that I just want to comment on of what Sarah had said in one of her last statements was with regards to caregivers or patients not feeling like their need is bad enough and kind of deprioritizing their own resources, because that's something that we've heard a lot. And I worry something that risk-based screening is at additional risk of, because people may feel that they shouldn't state this. They shouldn't state that they have that risk or that they want those resources or that they want that emergent support, because it's not as bad. We've heard this time and time again in our qualitative work. It's not as bad as others have it. And I want to save those resources for somebody else. So I always think about and am interested in opportunities to test, interested in all of your perspectives on this as well, how it is that we can help prioritize the limited resources that we have in ways that meet families where they are. And I saw that comment in the chat as well, letting people decide what is right for them and how we can emphasize the strength of the communities and the strength of our patients and caregivers.
Thanks so much, Danielle. Jen, do you want to add something to that? I see you came up.
Yeah, I mean, I cannot speak as a clinician, so I'm so grateful to have that perspective. I think from a research side, I still feel like we don't know enough about the impacts of screening and especially screening alone. So your work, Laura, and others, we've have an understanding that most people say like, yeah, it's reasonable to ask me these questions, or it's okay if my doctor talks to me about this. But I think beyond that, it's harder for us to understand like what happens when you do this in clinical care, how much adjustment is being made, what does that look like? because so many social care interventions are targeted by screening. It's this package deal. And so I think one thing we haven't really said is there's tons of screening happening in the absence of any assistance, right? Like somebody's telling you have to do it and you're doing it and you're not doing anything else. Like we got a special crew here that's building those relationships, that's really following up. And I'm not sure that's the majority. And so I think it's really important to figure out what screening alone might mean. I also just love what I love about Danielle's model is that, you know, for a long time, I thought about it's screening or not and universal delivery or not. And these aren't mutually exclusive things. You can universally deliver assistance and still screen. And I love that idea. And I think part of why I love it, and one thing I worry about with screening, is that these are all modifiable conditions. They could change tomorrow. Somebody could be fine today and they don't need it. And tomorrow, your kid was just in the hospital and you missed work. And like the last 12 months, I was fine, but now I don't have any money and I can't get food, whatever. You know how that happens. And so just taking into consideration what that means for maintaining a record of some screen that could change very quickly. And how maybe that universal delivery helps with that concern that these conditions are modifiable. Last thing, because I know we're short on time, but we also haven't talked about sharing, where we see a lot of people say in our qualitative work, like, well, I didn't need it or I didn't need it bad enough. We do hear that as well, but my neighbor did. I gave it to my neighbor. And we see it at a really high rate. It's like 50% of people saying, I told someone else about something that you gave me, or I asked about a resource that my neighbor needed, not me, which I think is really important and difficult to measure, like the impacts at a larger scale when we're really focused on these individual outcomes.
Super, super helpful. I was really struck, and I think this resonates with one of the comments in the chat from Greg about the differences that both of you saw between the people who are asking for resources and the people who endorsed a particular social risk. And that's actually work that Amelia DeMarcus from our team had. She'd done some work on that, trying to find across lots of different studies those differences, and then you both elevated it. One of the things that was interesting to me, I think, if I interpreted your data right, is that Jen, you saw that more people are being missed who were higher income and who were white, I think, who were less inclined to endorse need, but still wanted resources. And Danielle, you found the opposite, that it was people from minoritized backgrounds and lower income backgrounds. I think if I remember that right, it seems to me like something that we need to also be looking at more carefully about all those different sources of bias and that are coming from the data that is being documented around social risk. Did I get those numbers right? I know we have to end
For
soon.
us, it depends on the need, but you're right that for foods and for housing, it was people who had higher annual incomes were being missed. For transportation, people who are African American or Black were more likely to be missed than
That
white
really
people.
depended.
And the income questions, I put this in response to Greg. I think there's some face validity to that because a lot of times risk-based questions are around money. And people don't want to admit they don't have the money or they find a way to do it. So I can scrape up enough food, but it's not going to be healthy. It's not what my kid needs, but I can figure it out. Or I don't have a stove or I don't have a car to buy my groceries and I can't afford delivery. So there's a lot of other factors that people who wouldn't want to say it's a financial issue. I think that could come into play that are completely missed in some of those questions.
I'm so sad. I knew this was going to happen, but I'm so sad that we have to end. We are going to send out a link to the webinar recording and to some resources that the presenters have generously offered to add to the recording that will help answer some of the questions in the chat. We will also send the questions and answers to the participants, and if there's some additional comments you want to make to folks, we can track them down and send out those responses. So grateful to everybody for listening. I had a happy holiday slide that I was going to put up, but we're out of time, and so happy holidays. I got to do that all by myself. Wishing everybody a restorative, peaceful, very generous, filled with kindness next month. Yeah, thank you so much to our presenters and to the audience for joining us today.